Welcome to the deep dive. Today we are taking a really comprehensive look into the renal and urinary system.
Yeah, it's a big one.
It really is a core med-surg unit, and it touches, almost everything. Blood pressure, fluids, electrolytes, life-sustaining stuff.
Absolutely. And we're aiming to go deep, really get into the weeds to help you master this.
Because problems here, they escalate fast.
Yeah,
Become systemic crises.
that's the core issue. So our mission today really is to break down the pathophysiology, the clinical signs, those key diagnostics.
And crucially, the nursing management. What you actually do to keep patients safe when their kidneys are struggling.
Exactly. Patient safety is paramount.
Okay, so framework? When we talk kidneys, there's one main concept driving everything.
That's right. Fundamentally, it's elimination, getting rid of waste and excess fluid.
Simple enough, but
But it's a linchpin. If elimination fails, you immediately see chaos in fluid and electrolyte balance and acid-base balance. It's direct.
it doesn't stop there.
No way. Kidneys are huge for perfusion too, through hormones like renin, and even immunity, helping keep chronic inflammation in check. It's all connected.
Okay, so given things go wrong, let's get some vocabulary straight right at the start. Azotemia.
Right. Azotemia is that buildup of nitrogenous waste, think urea, creatinine in the blood. It's a lab finding, essentially.
But then there's uremia.
Yes, and that's the critical distinction. Uremia is when that azotemia causes actual clinical signs and symptoms.
Like what?
Nausea, vomiting, that metallic taste some patients describe, fatigue, maybe cognitive changes. It's the syndrome caused by the waste buildup.
Got it. Azotemia is the number, uremia is the patient feeling sick from it.
Precisely.
Okay, next term. Proteinuria, protein in the urine.
Which shouldn't be there, right? The kidneys filter, the glomerulus, is normally too fine for big molecules like protein. So proteinuria means filter damage.
Then there's an early warning sign.
Yes, microalbuminuria, tiny amounts of albumin leaking through. You often won't catch it on a standard dipstick.
How much are we talking?
If it's persistently over about 80 micrograms in a 24-hour collection, that's a big red flag, especially for patients with diabetes or hypertension signals early, often silent, kidney disease.
Good to know.
Ah.
And finally, something common, especially in older adults, nocturnal polyuria.
Right, just means excessive urination at night. Often comes with a really strong sense of urgency. It relates to changes in how the kidney tubules concentrate urine as we age. So, to understand failure, we need the basics. Anatomy first. Kidneys are retroperitoneal.
Meaning behind the abdominal lining.
Exactly. High up, flanking the spine, you've got the outer cortex, then the inner medulla with its pyramids.
And the urine flows from the tips of those pyramids, the papillae.
Correct, into collecting structures called calyces, which funnel into the renal pelvis, that wider basin area.
Then down the ureters.
Yep.
And the sources mentioned pinch points.
Yes, 3 key narrowings. The UPJ, where the pelvis meets the ureter, where the ureter crosses the iliac artery, and the UVJ, where it enters the bladder. Prime spots for stones to get stuck.
Makes sense.
Yeah.
And kidney size tells a story.
It can. Unusually large kidneys might suggest something acute like an obstruction, inflammation, or maybe polycystic kidney disease.
Whereas small kidneys.
That usually points to chronic damage, scarring, fibrosis, the classic sign of chronic kidney disease, or CKD.
Okay, let's zoom in. The nephron, the functional unit.
This is where the magic happens. Blood flows in via the efferent arteriole.
Into the glomerulus.
Right, that high-pressure capillary tuft. Filtration happens there, across a specialized membrane into Bowman's capsule. That filtrate production rate is the GFR.
Glomerular filtration rate, and the volume is staggering.
It really is. Averages about 125 milliliters per minute.
Which works out to 180 liters a day.
Yeah, 180 liters filtered every single day. It's incredible.
But obviously we don't excrete anywhere near that much.
Exactly. Over 99% gets reabsorbed back into the blood by the tubules. That filtration process itself is based on size exclusion.
Meaning big things stay out.
Correct. Blood cells, albumin, other large proteins they should not get through. If you see them in the urine, that's clear evidence of glomerular injury.
And that reabsorption process has limits, right? Especially for things like glucose.
Absolutely. That's the renal threshold, or transport maximum. For glucose, it's typically around 180 milligdl in the blood.
So if blood sugar goes higher than 180,
the glucose transport pumps in the tubules get overwhelmed. They can't reabsorb it all, so the excess spills into the urine. Glucosuria.
Which explains the large urine volume in uncontrolled diabetes. The sugar pulls water with it.
Precisely. Osmotic diuresis.
Beyond filtering, the kidney is also an endocrine organ. Hormones are key.
Three major ones. First, the juxtaglomerular complex. Specialized cells there sense blood pressure, volume, and sodium.
And if they're low.
They release renin. Renin triggers the whole renin-angiotensin-aldosterone system, or RAAS,
Leading to vasoconstriction, sodium, and water retention.
all aimed at bringing blood pressure and volume back up. It's a critical feedback loop.
What are the other two hormones?
Erythropoietin, or EPO. It tells the bone marrow to make red blood cells. Lack of EPO is why CKD patients get so anemic.
Makes sense. And the third?
Activated vitamin D. The kidney performs the final activation step, which is essential for calcium and phosphate balance and ultimately bone health.
Okay, let's talk aging. How does getting older affect elimination?
Well, the tubules become less efficient at concentrating urine.
Leading to that urgency and nocturnal polyuria we mentioned.
Right. Plus, the body gets worse at regulating acid and sodium, and importantly, the thirst mechanism often gets blunted in older adults.
So, less concentration ability, poor regulation, less thirst drive. What's the big risk?
It sets them up for dehydration and specifically hypernatremia, high sodium levels. They lose water, especially at night, but don't feel thirsty enough to replace it adequately. Makes them very vulnerable.
Okay, let's pivot to diagnostics, reading the labs.
Two key blood tests. First, serum creatinine.
Why is it the best indicator?
Because it's produced pretty constantly from muscle metabolism and cleared almost entirely by the kidneys. Its level directly reflects GFR.
And there's a rule of thumb.
A useful one. If the serum creatinine level doubles, it generally means the GFR has dropped by about 50%, a significant loss of function.
Then there's BUN, blood urea nitrogen. Always trickier.
Much less specific, yeah. BUN is affected by hydration status. It goes up in dehydration. Also influenced by protein intake, muscle breakdown, even GI bleeding.
So you look at them together, the ratio.
Exactly. The BUN creatinine ratio. If it's high, say greater than 20.1, but the creatinine is normal or only slightly up, it often points towards a prerenal issue, like dehydration. The kidneys are trying to hold on to water, and urea gets reabsorbed along with it.
This leads us to a huge safety point. Contrast dye.
Absolutely critical, a major nursing safety priority. If a patient's baseline serum creatinine is 1.5 milli-GDL or higher,
They're at high risk.
high risk for contrast-induced acute kidney injury, or AKI, we must know that baseline creatinine before sending anyone for a CT with contrast or an angiogram often needs prehydration with IV fluids.
And there's a critical drug interaction tied to this.
Yes, metformin, very common diabetes drug.
What's the risk?
Lactic acidosis. It's rare, but potentially fatal, especially if the patient develops AKI after the contrast.
So the rule is,
Strict protocol. Metformin must be stopped 24 hours before the procedure and held for at least 48 hours after. And you must recheck kidney function before restarting it. Non-negotiable.
okay, let's look at the urine itself, urinalysis.
Best specimen is the first morning void. It's the most concentrated.
What are you looking for first?
Specific gravity. Normal is about 1.005 to 1.03 or 0. If it's consistently low and fixed, say around 1.01 arrow, that tells you the kidneys can't concentrate urine anymore. A hallmark of advanced CKD.
Protein again. Always bad.
Persistent protein is always concerning. Starts as microalbuminuria, progresses to overt proteinuria as the glomerular filter fails more.
And the sediment? What's down there?
We look for cells. RBCs suggest bleeding, maybe from GN or stones. WBCs or pyuria mean infection or inflammation.
But the really significant finding.
Casts. These are like molds of the tubules formed from clumped cells, protein, or bacteria. Finding casts almost always points to intrinsic kidney disease, something serious going on within the kidney tubules themselves.
All right, let's move into common problems with elimination. Starting with urinary incontinence, UI, often swept under the rug.
It is, and it shouldn't be. The key definition. UI is involuntary urine loss, bad enough to cause social or hygiene issues. And critically,
It's not normal.
absolutely not. Not a normal part of aging, not an inevitable result of childbirth. It's a medical condition and often treatable. We need to normalize talking about it.
What's the basic mechanism of staying continent?
Simple physics, really. Urethral pressure needs to be consistently higher than bladder pressure. Incontinence happens when that balance flips, where the bladder muscle contracts when it shouldn't.
Let's focus on the two main types. First, stress incontinence.
This is about the urethral sphincter failing. Urine leaks out during moments of increased abdominal pressure, laughing, coughing, sneezing, lifting.
Common in younger women.
Yes, especially after childbirth or menopause, due to weakened pelvic floor muscles.
And the second type, urge incontinence, sometimes called overactive bladder.
This is different. It's that sudden, intense urge to void, followed almost immediately by involuntary leakage. The patient just can't hold it.
What causes that?
An overactive detrusor muscle, the main bladder muscle, it contracts inappropriately, even if the bladder isn't full, can be linked to neurological issues, irritation, inflammation.
Okay, management. For stress incontinence, the go-to is often pelvic muscle exercises, Kegels.
Right, but the technique is crucial. Patients need good instruction.
How should they do it?
They need to isolate the right muscles, like trying to stop the flow of urine midstream. Then tighten those muscles, hold for a slow count of 10 seconds, and completely relax for 10 seconds.
How often?
Repeat that 15 times, and do the whole set lying down, sitting up, and standing. So 45 slow contractions total per day, plus adding some rapid flick contractions helps too.
What about for urge incontinence? More behavioral stuff.
Yes. For motivated, alert patients, bladder training works. Scheduling voids, then gradually increasing the time between them, teaching the patient to resist or suppress the urge.
And if the patient is cognitively impaired?
Then we use habit training or scheduled toileting. It's caregiver-driven, taking the patient to the toilet on a fixed schedule, like every 2 hours, before they have an accident.
There's a really important action alert here about habit training in briefs.
Yes, this is critical. Habit training fails if staff or caregivers just rely on absorbent briefs instead of actually toileting the patient on schedule.
Telling them to just wet the bed.
Exactly. It undermines the whole point, leads to skin breakdown, UTIs.
Yeah.
It's poor care. Briefs can be a backup, but not the primary strategy if habit training is the goal.
Okay. Pharmacologic options for urge incontinence.
Mainstay drugs are the anticholinergics or antimuscarinics, things like oxybutynin, darafenacin.
How do they work?
They block nerve signals that make the bladder muscle contract. So they relax the bladder, increase its capacity.
But there are side effects.
Definitely. Dry mouth, constipation, blurred vision are common. But the big concern, especially in older adults, is cognitive impairment confusion, memory issues. Need to use them cautiously.
Let's switch gears to infections. Cystitis bladder inflammation, usually a UTI.
Most often, yes, infectious cystitis. And the main culprit, over 80% of the time, is E. coli ascending from the gut.
And UTIs get classified.
As complicated or uncomplicated, uncomplicated is basically a healthy, non-pregnant woman. Everyone else, men, pregnant women, diabetics, people with kidney stones or catheters, gets classified as complicated. Needs closer attention, maybe different treatment.
In hospitals, catheters are a huge source of UTIs, the dreaded CI-UTI.
Huge problem. Catheter-associated urinary tract infections. It's the most common factor for new hospital UTIs. Risk goes up significantly every single day the catheter stays in.
Provides a direct highway for bacteria.
Pretty much.
So the safety priority is all about CI-UTI prevention. Best practices.
Starts with justification. Only insert if absolutely necessary, not for convenience. Strict aseptic technique during insertion.
And after insertion.
Daily assessment. Does the patient still need this catheter? Get it out ASAP. Keep the drainage bag below the bladder. Maintain a closed system. Meticulous hygiene during emptying. It all matters.
Preventing CA-UTI prevents.
Urosepsis. Sepsis originating from the urinary tract. Often starts as a simple UTI, especially CI-UTI, and can become deadly fast.
Are there non-infectious causes of cystitis?
Yes. Certain drugs like the chemo agent cyclophosphamide can irritate the bladder. Radiation therapy too.
And there's a chronic, painful condition.
Interstitial cystitis, or IC, also called painful bladder syndrome. It's chronic inflammation, likely immune-related, not infection. Causes terrible pelvic pain, urgency, frequency. Pain often gets worse as the bladder fills. Really debilitating. Okay, shifting now to obstruction, and the classic cause is urolithiasis, kidney stones.
What conditions lead to stone formation?
Two main things need to happen. First, the urine has to be supersaturated with stone-forming stuff, usually calcium, but could be uric acid, other things. Second, you need a nidus, a starting point, like a little crystal deposit for more crystals to latch onto.
And the biggest driver of that supersaturation?
By far, the most common factor is chronic dehydration. Concentrates the urine, makes stones more likely. Genetics plays a role, too, in how people handle minerals.
The pain is legendary, right? Renal colic.
Unforgettable if you've seen it. Sudden onset, excruciating, often described as unbearable. Patients are often writhing, pale, sweaty, nauseous.
Caused by the stone blocking the ureter.
Exactly. Causes intense ureteral spasm. The location of the pain gives clues. Flank pain usually means the stone is high up in the kidney or upper ureter.
And if it radiates down?
Towards the abdomen, groin, scrotum, or labia, that suggests the stone is lower down in the ureter.
What if the patient has severe pain and then stops making urine? Oliguria or anuria?
That's an emergency. Suggests complete obstruction. Pressure is building up behind the stone, damaging the kidney rapidly, needs urgent intervention.
So immediate priorities are pain control and trying to get the stone to pass.
Yes, pain control often needs opioids because it's so severe. NSAIDs like ketorolac are also used to help with pain and inflammation around the stone.
But a warning about NSAIDs.
Right. They can impair kidney function, especially in vulnerable patients, and they increase bleeding risk. Important if surgery might be needed.
And to encourage passage.
Fluids, fluids, fluids. Push intake to 2-3 liters a day to flush things through. And often medications like alpha blockers, tamsulosin, or calcium channel blockers are used.
How do they help?
They relax the smooth muscle of the ureter, potentially making it a bit wider for the stone to pass.
What if the stone is too big to pass, say, over 5 millimeter?
Then we look at interventions. Most common non-invasive one is lithotripsy. ESWL, extracorporeal shock wave lithotripsy.
Uses sound waves.
High-energy sound or shock waves, focused from outside the body onto the stone to break it into smaller, passable fragments.
Anything special during the procedure?
Yes. Critically, the shocks have to be timed with the patient's ECG, specifically the R wave. This prevents the electrical shock from triggering a dangerous heart rhythm.
What else could be done?
A stent might be placed internally in the ureter. It's a small tube that holds the ureter open, reduces pain and spasm while fragments pass.
And if the stone is really large or inaccessible?
Then a percutaneous nephrolithotomy might be needed. Surgeons go directly into the kidney through a small incision in the back to physically remove or break up the stone. Often leaves a temporary nephrostomy tube for drainage.
Let's talk about what happens if obstruction isn't relieved. Hydronephrosis and hydroureter.
It's simple mechanics. Urine backs up behind the blockage. If it swells the ureter, that's hydroureter. If the backup reaches the kidney itself, enlarging the renal pelvis and compressing kidney tissue, that's hydronephrosis.
And this is urgent. Damage happens quickly.
Extremely time-sensitive. The back pressure crushes kidney tissue, cuts off blood supply to the tubules, ischemia, necrosis. Permanent damage can happen in less than 48 hours with acute, complete obstruction.
So if you can't fix the obstruction immediately, you divert the urine.
Yes. That usually means placing a nephrostomy tube. A tube inserted directly through the skin into the kidney to drain urine externally and relieve that damaging pressure.
Which leads to a critical rescue point for nursing care?
Yeah.
What's the immediate danger with that tube?
Tube patency is everything. Post-op, you're watching for bleeding, infection, sure. But the #1 emergency is blockage.
Signs of blockage.
Decreased or absent drainage from the tube. Cloudy, foul-smelling drainage suggesting infection. Or the patient suddenly developing severe flank pain again.
What do you do?
Notify the surgeon immediately. Any of those signs mean the tube might be blocked or dislodged, pressure is building up again, and the kidney is actively being damaged. All right, moving away from plumbing issues to inflammation, let's talk glomerulonephritis, or GN. The filter itself is attacked.
Acute GN often follows an infection, right? Like strep throat.
Classic example. Group A strep is common. It's an immune reaction. Antibodies formed against the strep end up lodging in the glomeruli.
Triggering inflammation there.
Exactly. That inflammation damages the glomerular filter, makes it leaky. So things that normally stay in the blood proteins, red blood cells, spill into the urine.
What does that look like clinically?
The urine is often the big clue. Described as smoky, rusty, reddish-brown, or cola-colored. That's the hematuria. Patients also get mild to moderate hypertension, edema from fluid retention.
And maybe uremia symptoms if it's bad.
Yes, fatigue, nausea if kidney function really drops.
Then there's chronic GN. Different beast.
Very different outcome. It's progressive, leads to irreversible scarring of the glomeruli. Chronic GN always progresses to end-stage kidney disease, ESKD.
What are the hallmarks there?
GFR plummets. BUN and creatinine climb steadily. And a key finding, the urine-specific gravity becomes fixed around 1.010.
Meaning the kidneys can't concentrate or dilute urine.
Right. They've lost that ability completely. It signifies massive nephron loss. Patient will have severe fluid overload systemically.
Okay, next up. A major genetic disorder, polycystic kidney disease, PKD.
Hereditary condition. Fluid-filled cysts develop throughout both kidneys, eventually crowding out and destroying normal tissue, making the kidneys huge.
And the cysts aren't just in the kidneys.
No, that's important. They can also form in the liver, pancreas, spleen, and significantly, patients with PKD have associated vascular problems.
Leading to a major risk outside the kidneys.
Yes, a much higher incidence of cerebral aneurysms, aneurysms in the brain's arteries.
Which means
A sudden severe headache, often called the worst headache of my life, or sudden vision changes could signal a rupture. That's a neurologic emergency. Critical to educate patients about this.
So what's the main goal of managing PKD?
Primarily, strict blood pressure control. Keeping BP below 130/80, often with ACE inhibitors, is the best way to slow cyst growth, preserve remaining kidney function, and reduce that microalbuminuria. Patients need to monitor their BP closely and report headaches or vision changes immediately.
Let's touch on kidney cancers. Renal cell carcinoma, RCC.
RCC can be tricky to diagnose because it often presents with systemic symptoms first, called paraneoplastic syndromes.
How so?
The tumor cells themselves can produce hormones. So confusingly, a patient might have either anemia because the tumor destroys normal EPO-producing cells, or erythrocytosis, high red cell count, because the tumor is making its own EPO-like substance. Hypertension is also common due to renin production by the tumor.
What's the biggest avoidable risk factor for kidney cancer? And bladder cancer, too.
Tobacco use. Smoking is the #1 modifiable risk factor for both RCC and, even more strongly, for urothelial cancers.
Let's talk urothelial cancer then, usually in the bladder.
Most commonly, yes. The classic early sign, the one people need to know, is painless hematuria.
Blood in the urine, but it doesn't hurt.
Exactly. And it's often intermittent, comes and goes, because it's painless and might not happen every time. People unfortunately often delay seeking help, letting the cancer grow. Any unexplained blood in the urine needs investigation.
Okay, surgery. If a patient has a kidney removed in nephrectomy, what are the immediate post-op dangers?
2 big ones. First, hemorrhage kidneys are highly vascular. Second, adrenal insufficiency.
Why adrenal insufficiency?
Because the adrenal gland sits right on top of the kidney. It can be injured or might need to be removed along with the kidney during cancer surgery.
And the signs for both hemorrhage and adrenal crisis.
Early on, they can both present similarly: hypotension and decreased urine output. Adrenal insufficiency also causes significant electrolyte imbalances, particularly sodium loss. Very dangerous.
Yeah.
Okay, now we hit the big syndromes of kidney failure itself. We need to clearly separate AKI, acute kidney injury, from CKD, chronic kidney disease.
AKI is sudden, potentially reversible.
Right. Rapid onset, often triggered by a specific event like dehydration, a drug, sepsis. And if you fix the underlying cause quickly, the kidneys might recover.
Or as CKD.
That's gradual, progressive, irreversible loss of nephrons over months or years, defined by GFR stages.
Let's nail down the definition of AKI. It's based on rapid changes.
Yes, the universal definition relies on hitting one of 3 criteria within a short time frame, usually 48 hours. Serum creatinine increases by at least 0.3 mg/dL, or serum creatinine increases to 1.5 times the patient's baseline level,
Right.
or the patient develops significant oliguria, defined as urine output less than 0.5 milliliter per kilogram per hour for at least 6 hours. Any one of those triggers the AKI diagnosis.
And we categorize AKI based on cause: prerenal, intrarenal, postrenal.
Exactly. Helps guide treatment. Prerenal is about reduced blood flow to the kidney, dehydration, shock, heart failure. Kidney itself is okay initially. That's direct damage to the kidney tissue. Toxins are a big cause contrast dye. Certain antibiotics like aminoglycosides, NSAIDs, or prolonged lack of oxygen, ischemia, leading to acute tubular necrosis, ATN.
And postrenal.
That's an obstruction after the kidney, blocking urine outflow. Stones, enlarged prostate, BPH, tumors.
For AKI, prevention is key.
Absolutely paramount. Simple things like encouraging adequate hydration 2 to 3 liters daily for healthy adults. In the hospital, it means being vigilant about nephrotoxic drugs, monitoring levels, following those contrast protocols religiously.
That prerenal state, low blood flow, the kidney tries to compensate.
It does. RAS kicks in hard, trying to conserve volume, leads to that severe oliguria and azotemia as the kidney sacrifices waste excretion to hold on to salt and water.
Okay, let's turn to CKD. Staging is based on GFR.
Yes, 5 stages. Stage 1 is kidney damage with normal or high GFR, down to stage 5, which is ESKD, end-stage kidney disease with a GFR below 15. That's when dialysis or transplant becomes necessary.
And albuminuria adds another layer.
Right. Stages A1 to A3 track the amount of albumin leaking. More albumin means more damage and higher risk of progression in cardiovascular events.
Let's walk through the fluid and electrolyte changes in CKD. It's a bit counterintuitive, early versus late.
It is. In early CKD, stages 1 to 3 maybe, the remaining healthy nephrons are working overtime. They often can't reabsorb sodium efficiently, leading to some salt wasting. So patients might actually be at risk for hyponatremia. They might also still have polyuria.
But as it gets worse, stage 4, stage 5.
The remaining nephrons fail. Urine output drops dramatically. Now the body can't get rid of sodium or water. So patients become severely sodium retentive and develop massive fluid overload.
And the most dangerous, electrolyte imbalance.
Hyperkalemia. High potassium. Kidneys are the main route for potassium excretion. When GFR plummets, especially below 500 milliliter urine output a day, potassium levels skyrocket.
Levels above 7 or 8.
Extremely dangerous. Causes classic ECG changes, tall peak T waves, wide QRS, and can lead to fatal arrhythmias, VTach, VFib, systole. It's a true medical emergency. Needs immediate treatment to shift potassium back into cells or remove it.
What about acid-base balance in late CKD?
Chronic metabolic acidosis is inevitable. The kidneys lose their ability to excrete the daily load of acid produced by metabolism, and they can't regenerate bicarbonate effectively. Leads to a persistent low bicarb level. Often needs treatment with oral bicarb supplements.
And CKD hammers the cardiovascular system, right? This cardiorenal connection.
It's a vicious cycle. Hypertension is both a cause and a major consequence of CKD. The failing kidneys overactivate RAAS, causing vasoconstriction and volume retention, driving BP way up.
Which damages the heart.
Yes. Chronic high BP plus the fluid overload plus the anemia common in CKD. It all strains the heart, leading to left ventricular hypertrophy, LVH, and eventually heart failure. Very common.
And another cardiac risk.
Pericarditis. Uremic toxins can irritate the sac around the heart, causing inflammation. Can lead to tamponade if severe.
So managing fluid is constant vigilance.
Absolutely. Strict intake and output tracking is essential. But the single best indicator of fluid status.
Daily weights.
Yep. Same time, same scale, same clothes. Teach patients. A 1 kilogram gain overnight is roughly 1 liter of retained fluid. Nurses need to constantly assess for overload, listening for crackles in the lungs, checking for edema, looking for JVD.
Nutrition is huge too. What are the key restrictions?
It depends on the stage and if they're on dialysis. For non-dialysis CKD, usually stages 3B to 5, protein is restricted, often down to 0.6 grams per kilogram per day. Helps reduce the nitrogen waste load.
What about phosphorus?
Phosphorus restriction is vital. High phosphorus pulls calcium from bones, leading to terrible bone disease, renal osteodystrophy. Patients need to limit high phosphorus foods and take phosphate binders.
When do they take the binders?
Critically important with meals. They have to be in the gut with the food to bind the dietary phosphorus so it's not absorbed.
Anything else to avoid?
Antacids or laxatives containing magnesium. Failing kidneys can excrete magnesium, leading to hypermagnesemia, which causes muscle weakness, respiratory depression. Dangerous.
Drug therapy. What's key for slowing progression?
ACE inhibitors, or ARBs. They are first line for hypertension in CKD, and they help protect the kidney itself by reducing pressure inside the glomerulus, lessening proteinuria.
What about diuretics?
Used commonly in mild to moderate CKD for fluid overload, but used cautiously in late CKD-ESKD. Loop diuretics like furosemide become less effective as GFR drops, and high doses carry a risk of ototoxicity, permanent hearing loss.
Okay, so when GFR falls below 15 and conservative measures aren't enough, we need kidney replacement therapy. Most common is hemodialysis HD, requires special access.
The patient's lifeline, literally. The best option, the gold standard, is an AV fistula, surgically connecting an artery directly to a vein in the arm.
Takes time to mature.
Yeah, usually 8 to 12 weeks. The vein needs to arterialize, get bigger and stronger to handle the dialysis needles and flow rates. If a fistula isn't possible, an AV graft using synthetic tubing is the next option.
This access needs serious protection. Huge safety priority. What are the absolute rules for the access arm?
Cannot emphasize this enough. No blood pressures, NO-YV starts, and NO venipunctures in the arm with the fistula or graft. Ever. Compression or puncture can cause clotting, thrombosis, loss of the access.
And how do you check if it's working?
You need to assess it every shift, at least every 4 hours while awake. Palpate for the thrill, that buzzing feeling of turbulent blood flow. And auscultate for the bruit, the whooshing sound. Thrill and bruit mean it's patent. Absence is an emergency.
Medication management around HD treatments is tricky too.
Very. Because dialysis removes waste, it also removes many medications from the blood.
So you have to hold certain drugs.
Yes. Need close coordination with pharmacy and nephrology. Many common drugs are dialyzable, lots of antibiotics, some vitamins, and importantly, many blood pressure meds. These usually need to be held until after the dialysis treatment.
Why hold BP meds?
Giving them right before or during dialysis can cause dangerous drops in blood pressure during the treatment. Intradialytic hypotension.
Okay, let's talk about the other main type, peritoneal dialysis, PD. Uses the patient's own body.
Right. Uses the peritoneal membrane lining the abdomen as the filter. Dialysis fluid is instilled into the peritoneal cavity via a catheter.
What are the steps?
3 phases. Infusion, or fill putting the sterile dialysis in. Dwell letting it sit there for a prescribed time, allowing waste and fluid exchange across the membrane. And drain, removing the fluid, now called the effluent, which contains the waste products.
What's the biggest, most feared complication of PD?
Peritonitis,
Yeah.
infection of the peritoneal cavity, usually from contamination during connection-disconnection procedures.
What's the cardinal sign, the thing you absolutely look for?
The earliest and most important sign is cloudy or opaque effluent. The fluid coming out looks milky or hazy instead of clear, often with abdominal pain, maybe fever.
What do you do if you see cloudy fluid?
Treat it as peritonitis until proven otherwise. Get a sample of the effluent for immediate cell count, gram stain, culture, and sensitivity. Start antibiotics right away based on protocol. It's serious.
Finally, the most definitive treatment, kidney transplantation.
The gold standard, yeah. Offers the best quality of life. Success hinges on good matching blood type compatibility and, crucially, HLA typing, human leukocyte antigens, to minimize rejection risk.
Well, living donors are best.
Living donor kidneys generally last longer and work better immediately. We even see things like the NIAID chain, never-ending altruistic donor chains. Someone donates to a stranger, starting a chain that eventually helps their own incompatible loved one get a kidney. Pretty amazing.
Post-transplant, what's the key thing to monitor immediately?
Urine output, hour by hour initially. A sudden drop, oliguria, is a major warning sign. Could mean dehydration, a clot in the renal artery, leaking at the surgical connection, or
Rejection.
acute rejection, yes. That's the most common type, especially in the first few months to a year. Usually treatable with higher doses of immunosuppressants, but needs rapid diagnosis.
And the downside of those immunosuppressants.
Infection risk. It's the leading cause of death in transplant recipients. The drugs that prevent rejection also suppress the immune system's ability to fight off bacteria, viruses, fungi.
And the drugs mask infection signs.
They do. Classic signs like high fever might be absent, so you have to be alert for subtle things. A persistent low-grade fever, slight confusion or mental status change, just vague feelings of malaise or discomfort. These can be the only clues.
So adherence to the anti-rejection meds is
Absolutely paramount, non-negotiable. Missing doses dramatically increases the risk of rejection and losing the precious graft. Hashtag tag outro.
So we've covered a lot of ground today, from the elegant filtration of the nephron and the power of hormones like renin, all the way to the devastating systemic effects of AKI and CKD. We've seen how elimination failure impacts everything: fluids, electrolytes, acid base, leading to critical risks like hyperkalemia or urosepsis.
And hopefully we've highlighted the nurse's vital role in all this. Vigilance is key, preventing things like CAUTI, protecting that dialysis access, recognizing obstruction or hyperkalemia fast.
Exactly. It's about meticulous assessment, careful monitoring.
Yeah, those core skills are essential. Daily weights, tracking BP, knowing those safety protocols inside out the metformin contrast rule, AV access care, and empowering patients through education, Kegels, diet, fluids.
Absolutely.
It really underscores the complexity and the importance of this system. It does. And maybe a final thought to leave you with, connecting this all back to the bigger picture. We know CKD is incredibly common, often linked to hypertension, diabetes, obesity, things that are also widespread.
And many people didn't even know their kidneys are damaged early on.
Precisely. So thinking about that, consider this. How might our approach to health change if routine screening, maybe using something like the urine albumin to creatinine ratio, the UACR, became standard practice in primary care much earlier?
Catching damage sooner.
Exactly. Could wider, earlier screening fundamentally shift our focus towards prevention, maybe dramatically reducing the number of people who eventually need dialysis or transplant down the road? It makes you think about the potential impact of proactive health promotion on kidney disease burden.
That's a really powerful thought. How proactive screening could change the landscape entirely. Well, thank you for joining us on this deep dive into renal and urinary care.
Hope it was helpful.
We certainly hope this comprehensive review helps you build the mastery and confidence needed for safe, effective patient care.
Thanks for listening.